Good evening, everyone, and welcome to our virtual CME event provided by GI Health Foundation about congenital sucrase isomaltase deficiency, or CSID 2020, recognizing and managing CSID in pediatric patients. If I have the next slide, it's my pleasure in a little bit to introduce you to our main speaker this evening, Dr. Tanaz Danalifar of Pediatric Gastroenterology, Children's Hospital, Los Angeles in Los Angeles, California. Before we get going into the meat of the evening, I'd just like to do a few thank yous and housekeeping moments. Next slide, please. The GI Health Foundation and Rehoboth McKinley Christian Health Services would like to thank our supporter for this evening, who's provided an educational grant to support. That's QOL Medical. Next slide, please. The disclosures have been submitted by the faculty here and are presented on this slide. Dr. Danalifar discloses being a speaker and consultant for QOL Medical. And I guess I should introduce myself. I'm Dr. Joel Rosh, Pediatric Gastroenterology at Goriab Children's Hospital in New Jersey, and I'll be moderating this evening. And I've disclosed that I've received grant and research support from AbbVie and Janssen, and I've been on advisory boards for Bristol Myers Squibb, Janssen, and Pfizer. Next slide, please. The accreditation statement appears here, and most importantly, this has been approved by Rehoboth Medical for a 1 credit of CME, and physicians should only claim credit commensurate with the extent of the participation in this evening's activity. Next slide, please. The objectives of this evening are to describe the prevalence of CSID in pediatric patients with common GI disorders, recognize the various phenotypes of CSID in pediatric patients, differentiate CSID from other causes of persistent diarrhea that are seen in clinical practice, especially among pediatric patients with suspected irritable bowel syndrome or IBS. And this evening, we'll also be summarizing the benefits and limitations of current treatment strategies for CSID. Next slide, please. So to get us to all those objectives this evening, it is again my privilege and honor to introduce our speaker, Dr. Tanaz Danalifar of Children's LA. Dr. Danalifar.
Thanks, Joel. I want to get us started with a case presentation. This is a patient I saw fairly recently. It's a 16-year-old male. He was referred as a second opinion for chronic abdominal pain. He had first started having issues several years ago, about age 7, after a prolonged course of antibiotics. His evaluation at that time was notable for lactase deficiency, and he had an insufficient response to just a lactose-free diet. So the pediatric gastroenterologist at the time had diagnosed him with IBS, and he responded to a low FODMAP diet. Over time, he was less adherent to the low FODMAP diet and had developed progressively increasing abdominal symptoms. So at the time that I saw him, he was having daily symptoms as well as exacerbations twice a week, characterized by more severe pain, nausea, and diarrhea, which for him was increased stooling frequency, up to 5 stools just in the afternoon hours. He also complained of frequent gassiness and bloating, especially related to his meals. He had already restarted his low FODMAP diet for over a month prior to seeing me, and he had had an insufficient response to that. Just to review his prior evaluation and treatment, you have all the labs on the left-hand side. A lactose breath test was positive. He had an insufficient response to that. He'd also had extensive food allergy testing, which was unremarkable. In terms of medications, simethicone and bismuth, no response, and dietary therapies we already reviewed.
So Tanaz, if I could ask you a question at this point, I think most clinicians would recognize this as a potential functional gastrointestinal disorder, such as irritable bowel. Would you agree with that assessment?
I would, and I think that's where many of us start. We know there's a really increasing prevalence of functional GI symptoms among pediatric patients, up to 12% prevalence of IBS, up to 40% prevalence of abdominal pain in elementary school age children. The problem is that many patients are not satisfied with their treatment. If you look at this data, the vast minority of patients feel satisfied with their treatments for IBS, including alternative therapies. For myself as a practitioner, I feel the same way. So that takes us back to looking at the diagnosis. And if we're having insufficient response, are we missing something? So as part of our differential, when we want to diagnose IBS, we think about microscopic colitis, celiac disease, non-celiac gluten intolerance, bile acid diarrhea, food allergy, and SIBO. And those come to mind frequently. Something I'd like to suggest is also thinking about the role of disaccharidase deficiencies. So before we do that, let's just review a little bit about normal carbohydrate digestion. Digestion starts in the mouth with amylase and then continues in the small intestine. Monosaccharides are the only ones that we can absorb through the small intestine. So disaccharidases, such as sucrase, are responsible for digesting into individual monosaccharides, which can then be transported. When we think about cases of sucrose malabsorption and the altered gut physiology that happens, you have residual sugars that sit in the intestine. They cause irritation, increased motility, influx of fluid, which will give you more irritation and increased motility. They also become the subject of bacterial fermentation. We get more production of gases as well as diarrhea. And the combined effect gives you gassiness, diarrhea, bloating, and pain. When we think about disaccharidase deficiencies, we can divide them into the genetic causes. Those are going to be the primary disaccharidase deficiencies. And there's both congenital lactase deficiency and congenital sucrase isomaltase deficiency. And we'll talk a little bit later on about the various genetic components. It's also really important to make sure that we've eliminated the secondary causes. And those are going to be any condition that gives you small bowel injury, specifically brush border injury, where your disaccharadases are located. And you'll have secondarily decreased disaccharadases. Those causes are usually reversible by treating the underlying etiology.
So Tanaz, thank you for the refresher on normal physiology. It's always helpful to see. And this is interesting. What's your sense? How common is CSID?
That's a little bit of an interesting question, because we know historically the very traditional congenital sucrase isomaltase deficiencies, and those are those super deficient patients which carry a known genetic marker, were infrequent. In North American populations, less than 0.5%. A few select populations, such as Greenland Eskimos and Alaskans, have much higher frequencies. If we look at some newer data, this is a subgroup of all comers for endoscopy, and these are pediatric patients. Over 45% of them had at least one disaccharidase deficiency. Of those, 21% of any disaccharidase deficiency was sucrase deficiency, which comes out to a 9.3% sucrase deficient overall. This doesn't really differentiate primary and secondary causes. In another study where you look at a group of more symptomatic patients, these are patients with chronic abdominal pain as their reason for going to endoscopy. About 20% of that subset was sucrase deficient as well. And a large number of them were both sucrase and lactase deficient. It's also interesting to take a look at some of the adult literature, because we think about it usually as an infant problem. But this is an adult study where they took patients with chronic GI patients and gave them a sucrose breath test. About 22% of that subset had a positive or an abnormal sucrose breath test as well.
So Tanaz, how does this correlate? How does this feel to you in the pediatric population? Does this data ring true for you?
It's pretty accurate. We actually recently did a study looking at pediatric patients at our institution referred for lactulose hydrogen breath testing. So these are patients coming with common symptoms such as abdominal pain, gassiness, diarrhea. And we gave all of those patients a sucrose breath test as well. About 20% of that subset had abnormal sucrase testing. What was interesting to me is that many of those patients actually were not positive for SIBO as well, so they didn't always correlate. So it's really kind of opened this question of, are we missing CSID as one of the diagnoses when we're diagnosing IBS?
Well, if that's the question, then how does CSID usually present clinically?
One of the original presentations was really this infantile form, and it was reported in a case series in the Lancet in the 1960s. They were children who had failure to thrive, significant diarrhea with a very severe diaper rash, because this was a really acidic kind of diarrhea, irritability, and vomiting. And one of the real hallmarks was that the symptoms started on introduction of solids to the diet, because prior to introducing solids, there's not really any sucrose or starch in the infant's diet. More recently, I've been seeing, and many people are describing, more variable presentations. Those can be patients with chronic bloating, more subtle chronic failure to thrive, irritability related to meals, abdominal cramping, gassiness, nausea and vomiting, chronic diarrhea. So it can really look like the full spectrum of any functional GI disorder. Coming back to our patient, he has a lot of those things. He has chronic abdominal pain, he has diarrhea, and he has gassiness as well as postprandial symptoms, which make me think of a dietary source or some sort of a malabsorption.
Yeah, but at the same time, I think we all can appreciate just how common these symptoms are. So if one already is thinking about CSID, what's the best way to screen and diagnose it?
We have a couple of options, and I'll go through them with you, and then I'll share my approach as well. We'll go through each of these: biopsy, genetic testing, breath testing, as well as sucrose challenge. Enzyme testing via disaccharidase assay has traditionally been the gold standard. It requires anywhere from 2 to 3 duodenal biopsy samples. Those are preserved on ice and sent to a specialty lab where they actually look at quantitative function. And you have in here the reference ranges for normal for sucrase as well. So the benefit of this testing is you can really differentiate primary and secondary etiologies of sucrase deficiency, because you know that you'll have normal histology in those cases. You can also evaluate for any concomitant other disaccharidase deficiencies, most commonly lactase deficiency. The big limitation is it's invasive, it's expensive, it's going to require anesthesia. There are also some issues around the handling of the sample, because they need to be preserved on ice and make it to the laboratory in a special way. And some issues around variability of the assays depending on which lab they're done at. The C13 sucrose breath test is one of my favorites for diagnosis, and I'll give you a few reasons. The basis of the study is you look at the expired production of the tagged carbon molecule. The patient drinks a tagged sucrose load, then they give measures over every 30 minutes for 90 minutes. And we look for how much they expire. The main restriction here is an 8-hour fast, so easy to do first thing in the morning, 1 week of no antibiotics and no antihistamines or NSAIDs. There's no diet for the day before, which is different from hydrogen and methane testing. The testing is simple. It's also provided free of charge through Metabolic Solutions, and it's done at home. So when I refer my patients, a test kit gets sent to them in the house, and I've had really great compliance, even children as young as 4 years old. Some of the limitations is there's limited data on the predictive values. We can't tell anything about small bowel health and secondary etiologies for disaccharidase deficiencies. And there's some compliance issues. You have to select the right patient for it. Some patients who really are very sucrase deficient may become symptomatic actually during the test, and that's actually important information that we can collect at the time of the test as well. The hydrogen methane breath test has fallen out of favor a little bit. This is done similar to how we do our lactose or lactulose breath testing, and we're looking for a rise in hydrogen production, which reflects the bacterial fermentation of the sugars. It's simple, can be done at home or in the office, depending on your clinical practice. My biggest concern is that any bacterial overgrowth is going to affect this. Motility issues are going to affect this as well. There's also a lot more required in terms of avoidance of fermentable foods, antibiotics, pro-motility agents for the day prior to testing. So it's been a little bit more of a challenge to get my patients totally compliant with this testing. The last thing to talk about is, and this is if you really don't have access to any of the other testing methods, 4-4-4 sucrose challenge. And it's really quite simple. You stir 4 tablespoons of table sugar, which is mostly sucrose, into 4-ounce glass of water, drink it on an empty stomach. And I would add in here that it should be done within about 15 minutes or so. Then for the next 48 hours, monitor for symptoms, bloating, gassiness, and diarrhea. So it's simple and easy, it's inexpensive. The challenge is in pediatric patients being able to really elicit from them those symptoms in a reliable way. We also, if we have any differences in their motility or gut transit times, we're going to see differences in symptoms. And some children can become very symptomatic. It's a very large sucrose load for them. Coming back to our patient, to round out his repeat evaluation, he had repeat labs. We did a C13 breath test, which was actually consistent with low sucrase activity. I also concomitantly did a lactulose hydrogen methane breath test, which was negative. There was no evidence of SIBO. His occult blood testing and stool H. pylori antigen were negative.
So it's very helpful to see the diagnostic options. You had put out small bowel biopsy and disaccharidase analysis as the gold standard. So what about a patient who has a positive C13 breath test, maybe even responds clinically to replacement therapy, but you did biopsy and you did not find yet a non-diagnostic analysis on the biopsy? How do you balance that data?
It's a good question. And I think part of what that goes back to is where the cutoffs come for the biopsies. So the standard normal is 50 plus or minus 25. The lab is only going to call an abnormal result at less than 25. Those values were made from our very initial cohort of really severe patients diagnosed during infancy. So I take a look at the disaccharidase levels, and in my clinical practice, I've treated children with levels in the low 30s, for example. Also worth thinking about is, was there any issue in the transport mechanism? And was there variability in the biopsy sample location, which is why some labs recommend more than one biopsy result. Just to kind of take a deeper look at whether the cutoffs are reliable cutoffs. This is a paper that is published online recently, hasn't even come out into print in JPGN, where they looked at sucrase isomaltase pathogenic variants in patients who had had small bowel biopsies with disaccharidase testing. And if you look at, the low sucrase patients were very frequent carriers of those pathogenic variants. That's your blue bar. The middle bar actually moderate sucrase activities. So those are from the actual cutoff of abnormal, which is 25, to 55, which is the middle range of the normal. And of those moderate sucrase patients, a good number of them actually carried pathogenic sucrase isomaltase variants. So to me, this suggests that we should look a little bit more closely at what the levels are.
So in thinking about that, when you send tissue for disaccharidase analysis, you get back results on all of them. So what's your approach in the patient who has multiple, even pan-disaccharidase deficiency?
First reaction often is the tech messed up, the nurse messed up, the sample didn't end up on ice, and there's something wrong with the whole thing. And before you throw out the whole thing, I like to take a little bit of a deeper look. First thing is that we know that lactase deficiency is very frequent. So it's possible that a patient could be sucrase deficient and lactase deficient at the same time. This is the same study. If you look in the pink box, they looked at the prevalence of SI pathogenic variants in patients with pan-disaccharidase deficiencies. So these are patients who are deficient in all of the disaccharadases, but in up to 20% of the patients, they actually carried pathogenic variants. Looking at those with abnormal lactase and abnormal sucrase, over 20% of those patients as well. Coming back to our patient, I wanted to add a little bit of a twist because it's pre-COVID, you would see patients, they'd come back with their families. And this time I was really surprised. He came back with his grandmother, who told me that when they had started hearing about her grandson with a diagnosis of something related to sugar, it really struck a chord with her. She had had chronic diarrhea since being a teenager. And 1 year before that had been diagnosed with type 2 diabetes and started on a low carbohydrate diet. And her diarrhea had completely improved. And they were all so confused by this. And then when they started hearing about the grandson, they started questioning grandmother. So we sent a C13 breath test on grandma, who also has abnormal sucrase digestion, which may explain her chronic symptoms as well.
It's interesting, and it goes back to the data you showed us before of maybe borderline asymptomatic, and maybe that has something to do with our high sucrose diet in kids. You wonder if the
Mhm.
more sugar they're taking, the more symptomatic, and we need to raise the bar. So you have a multi-generational picture here. Can you tell us a little about the genetics?
I'm showing you this slide not to get deep into the genetics, but more just to understand that the sucrase isomaltase gene is a very large gene, which means there's a lot of opportunity for pathogenic mutations. We know that there are over 2,000 rare variants, and over 800 of those are considered to be pathogenic variants. In 31 biopsy diagnosed truly low sucrase patients, 60% of them had at least one of the four most common alleles. And we're seeing now that they may be homozygous, compound heterozygotes, or simple heterozygotes as well. When we think about the ways to do genetic testing, the options are buccal swab, saliva sample, or blood sample. In my clinical practice, I will often use a buccal swab if I feel I need to do genetic testing. The current test will only test 37 of the common pathogenic variants. And we said there are over 800 pathogenic variants and 2,000 known variants. So I think it really lends itself to say that for first line or screening, genetics testing is really not helpful. And it can be costly and difficult to get done for your patients. But understanding the genetics of CSID has been helpful in terms of looking at what can be the clinical picture. So here we looked at, is there a relationship between SI genetic variants and unexplained abdominal symptoms? What they found is that family members of CSID patients who were heterozygote genetic variants actually demonstrated reduced, but not at the threshold of abnormal sucrase activity. Most of those patients also had chronic nonspecific GI symptoms. And when they did in vitro models to characterize the enzyme activity, many of them had 20 to 35% reduction in enzyme activity. This is another study where they looked at stooling frequency and correlated between genotype. So on the right, the pink one is a CSID patient and their stool frequency. Middle one is a heterozygote, and they still had higher stool frequency than the patient on the left, which is going to be the group that are totally normal.
So seeing the genotype phenotype is interesting. At the top of the hour, when you presented your case, we talked about how the teenager presented like irritable bowel syndrome. So can you give us some sense of the relationship between CSID and IBS?
I think it's evolving still. But if we look at some of the new data that's come out, it makes me start to wonder if there's a small subset of our IBS patients which really actually may be CSID patients. This study took chronic diarrhea or IBS-D patients and analyzed for it, and not all IBS is related to CSID. There may be a subset of patients who can improve. Another thing that might point in that direction is the value of a low starch, low sucrose diet in IBS symptoms. This is a study that came out of Australia where they put patients with IBS on low sucrose starch diets. And if you look, they have the individual symptom scores, and all the way on the right, the composite score. And the patients actually had clinically significantly improved IBS symptom scores on a low sucrose starch diet. The other common diet we think about when we talk about IBS is a low FODMAP diet, like our patient who had already been on a low FODMAP diet. This study actually took a look at those patients who were failures to the low FODMAP diet and looked to see if they were carriers of any of the SI genetic variants. So on the left, it's those patients who had adequate relief with the low FODMAP diet. The black bar are non-carriers. The blue bar are those carriers. So those who carried hypomorphic SI variants were less likely to respond to a low FODMAP diet. Then they took it one step further to say, well, does it matter how many hypomorphic genes you have? And it actually did. Those who were homozygous in the blue bar had a much lower response rate to the low FODMAP diet. I just want to highlight for you also that while a lot of people think the low FODMAP diet will capture a lot of high sucrose foods as well, It does, but there's actually some conflict there as well. So the foods in green on this table are allowed on the low FODMAP diet, but actually high in sucrose foods. So it's not going to actually help many CSID patients.
So can you give us a sense then of how CSID is treated?
There are two mainstays. First one is going to be dietary therapy, and we've talked a lot about a low sucrose, low starch diet. So the first step is usually treating the sucrose intolerance, because while all CSID patients are going to be sucrose intolerant, you actually may have, there are other genes which will code for maltose and take care of your starch digestion. So the first step is going to be to reduce the intake of dietary sucrose, which for pediatric patients can be a challenge. And you can get some really good dietary guidance on doing some of that. For those who had low maltase activity, you can add starch elimination, or for those patients who give a history of starch causing symptoms or who have an insufficient response to just a sucrose limited diet at first. The second option is actually an oral solution, which will give you a replacement saccharose enzyme. It's administered before or during meals and snacks, and there's a weight-based dosing. It should be mixed into beverages, shouldn't be heated, and it shouldn't be mixed into acidic beverages. And when we look at the data on use of oral saccharose in patients with CSID, this is biopsy-diagnosed CSID, 81% of patients became asymptomatic within 10 days of saccharose therapy. So going back to our patient, he was started on saccharose therapy and had resolution of symptoms, all of his symptoms. He got some dietary guidance as well. And over time, he felt like the effort it took to take his enzyme for small snacks just wasn't worth it. And, you know, being a typical teenager, he took the easy way out. So he chooses to eat low sucrose starch foods, but he'll dose enzyme at times when he knows he's going to be eating something that's really outside of his diet. And he's had a really excellent treatment response to that. Grandma was referred to an adult gastroenterologist. She's doing a low carbohydrate diet anyways. And I haven't heard back yet on how she's done, if she's made any other changes. So in conclusion, just wanted to reinforce that sucrose maldigestion can have varying clinical presentations, from really extreme infant presentations to much less specific adult presentations. CSID, or secondary sucrase isomaltase deficiency, may be frequently overlooked in patients with IBS-like symptoms. I would consider disaccharidase evaluation in any patient undergoing EGD for unexplained abdominal pain, because it's that one extra piece of information. And for IBS patients not responding to traditional therapies, consider non-invasive CSID testing like a breath test or a sucrose challenge. Finally, there's multifactorial treatment, both dietary and saccharose enzyme replacement. With that, I'll send it back to you, Joel. If there are any questions, we can address those.
Thank you, Tana. So I'm just going to remind people that are watching, they should feel free to submit questions as well. I have a couple, if that's okay. So in thinking about CSID and acquired, congenital and acquired, how do you differentiate the acquired patient from the congenital patient? Do you just at some point liberalize the diet and see if it gets better? Do you, once you've made the diagnosis, retrofit and go back to look for a secondary or a primary etiology of the secondary? What's your approach in differentiating the two?
You know, for me, it goes back to doing a really thorough initial evaluation. So those etiologies that would give you secondary deficiency are going to be chronic inflammatory conditions such as inflammatory bowel disease. You're going to look for celiac disease. So I will screen my patients with CBC, celiac panel, ESR, CRP. I do fecal calprotectins called blood testing and fecal alpha-1 antitryptase testing as well. For me, the A1AT is a good marker of small bowel health. If there's any injury, we'll see some leak. The other thing is I'll look for SIBO initially as well, because I have had some SIBO patients who can get some trace non-specific small bowel irritation. I'm treating or looking for this in patients who have chronic symptoms. So it really eliminates those that may be secondary to an infection. But if you've had prolonged symptoms after an infection, it is worthwhile looking for those as well. There's also a question about how long you need to continue therapy. And you touched on the variability of sucrose ingestion in children's diets versus adults' diets. And you can reevaluate the patient. Often what happens is they may just get lazy with their enzyme administration, and they'll realize they're still having symptoms, or they'll realize they don't need it as much, or they need it with specific foods.
It's very helpful. So one of the questions that's been submitted is I do look for SID, but I tend to only do it in young children. Is this too limiting given this discussion?
I think so. I think that, the historical presentation of the infants who develop symptoms with introduction of solids is not the whole picture. I think there's enough data out there to suggest that you can have, less enzyme that still will give you clinical symptoms. Do all of those patients need enzyme replacement? Can some of them do just dietary therapies and get response? Yes. But I think given how easy, especially with C13 breath testing, how easy it is to diagnose, it's for me been a really, really valuable addition to my toolbox. I think the most frequent age group that I have been diagnosing are going to be preteen to teenagers. And often it's they always had something wrong. He's always had problems. It was never that big of a deal. Now I realize it's been years and it's more of an issue, and they'll finally present.
That's helpful. What's your sense of the compliance with therapy when you start patients on? How do you follow them up? What's your routine as far as when you bring them back to the office? How do you monitor compliance, et cetera?
So if there's a patient who has already had any growth abnormalities, for me, monitoring the growth is going to be a really important part of the discussion. I want to make sure that we're stabilizing the growth. And those are going to be the more severe patients who are really malabsorbing the large amount of their carbohydrates and their sugars. For many other patients, I think their compliance really relates to how much their symptoms will affect life. The low sucrose starch diet gets challenging over time. And so I've had patients who chose dietary therapy and then, after 6 months said, this is just getting too much, and decided to go on enzyme. I also shared with you a teenager who doesn't like to dose their enzyme every time. For me, I look at it a little bit like how bothered people are by their lactose malabsorption symptoms. It's not clinically going to be harmful to them. They're not going to have actual tissue injury if they eat sucrose. They're going to be really uncomfortable. And so it's going to depend on their comfort level. Many people will start to get a sense of the diet and decide those foods they know they'll be okay with, those foods they'll probably not feel good with, and those foods that they really think that they need to dose enzyme with. One barrier I will add is that the enzyme has to stay cold. So for school-age children, this means either it has to stay in the nurse's office in the refrigerator, and then the children get a dose around lunchtime, or it's sent in a cold beverage kept on ice in the child's lunchbox because it's dissolved in liquid. So for school lunch, I've had a lot of families actually elect to go low sucrose starch for lunch and then dose enzyme for other meals.
Those are really pearls and tips of how to do this clinically. Thank you. In the data that you showed, can you just expand a little bit more on that palatinase data and what it means?
So that's looking at those patients who have multiple disaccharidase deficiencies, and some of the genes that encode sucrase isomaltase may also encode parts of palatinase. And so it just reflects, again, those pan-deficient patients, and that it's not always a sampling error or a biopsy problem, and some of them may actually truly be sucrase deficient. So my approach for those patients, if you have a biopsy and there's pan deficiency, first step would be to look at the degree of deficiency of each individual enzyme. And if they look really low across the board versus is one of them more significantly lower than the other ones. If there's any question, you can follow it. And this is really in the presence of normal histology. If there's abnormal histology, the entire thing is kind of out the window because they're all secondary deficiencies. If there's any question as to whether this is a true sucrase deficiency as the etiology of symptoms, you can either follow it up with genetic testing, understanding the limitations there, or by doing a more functional assessment. And that's going to be a breath test or a sucrose challenge.
So perhaps a final question, just a thought experiment. Where do you see the field going? So as there's more awareness of the potential for CSID and SID, what do you think the future holds?
I think the first thing is just kind of expanding our perception of what CSID actually looks like and considering it. You know, we all will ask, all in pediatric gastroenterology, we'll always ask what foods cause your symptoms, and we'll often be very specific about dairy and try to get to the root of lactose. Add sugar in there, add starch in there, and see if you can really elicit any of those symptoms. And when you have a patient who's unsatisfied with their therapy, who's really struggling with diets, look one step further. I think, you know, if you look over the course of time, how frequently we used to look for pediatric small intestinal bacterial overgrowth to now, that's vastly changed. So in the future, we may be looking differently at this as well. You know, where the data really is lacking, and hopefully we'll have more studies to address this question, is those patients with hypomorphic SI variants. How do they actually respond to therapy, whether it's a change in diet or introduction of low sucrose starch? I've shared with you guys some of my clinical experience, but being able to do some wider studies, take a look at ranges of sucrase activity and what their response would be to starting enzyme, for example. I think that's really going to change a lot of how we look at this as well.
Well, that was great and a great way to end. So as a pediatric gastroenterologist of a certain age, I welcome the education I just received in 35 minutes. I got a great course in a field that when I came up was something that maybe you'll see once if you were a very busy gastroenterologist. So this was really very eye-opening. So thank you, Dr. Dhanalifar, for that. I really appreciate it. I hope everyone that has joined us agrees. I'm sure they do. A couple of housekeeping reminders to close with. In order to receive your online accreditation certificate, there's a URL that is on your screen now. Please make sure to cut and paste it and fill out the evaluation form. Do I have a next slide? And that's my cue to say that I thank you all for joining. I thank QOL for the grant to be able to put on this program coordinated through GI Health Foundation. We do recognize that we're up against a political debate this evening, so we want to make sure we get you all out in plenty of time in case you want to tune in that. And thank you for joining us this evening.
Thanks so much. Bye-bye.
Bye-bye all.